My name is Henrik Zetterberg. I'm a professor of neurochemistry at University of Gothenburg and at University College London. My specialty is fluid biomarkers for Alzheimer's disease and other neurodegenerative dementias. I love the cliff-jack curves on the biomarker changes in different stages of Alzheimer's disease. And I think they have those curves have been extremely important to help understand what's happening in humans with the disease. So as I think all of you know, we have the amyloid cascade hypothesis on Alzheimer's disease. And this is based on genetic findings in families with Alzheimer's disease. And also it's also based on biochemical neurotoxic effects of aggregated beta amyloid. And there are so many data in support of this cascade, I think, but it has been extremely important to also see how we can test if the relevance of this hypothesis also in living humans. And then the biomarkers that we and others have developed for amyloid, tau, neurodegeneration, microglial activation, astrocytic activation, these biomarkers have made it possible to examine the amyloid cascade in living people who age with or without Alzheimer's disease. And those who eventually get Alzheimer's disease dementia, in longitudinal cohort studies, it has become clear that the first biomarker change that happens in these individuals is a lowering of the beta 42/40 ratio, which marks onset of amyloid pathology. And this happens as early as 15 to 20 years, according to some studies, in some individuals even a little bit earlier, before you have dementia caused by Alzheimer's disease. So amyloid comes first. A few years later, you start to get tau changes, which is most likely an amyloid influence on neurons in the brain. And then you also have an astrocytic and microglial activation that in the beginning looks like a beneficial protective response, but eventually as these pathologies accumulate, the microglial activation goes away, which is reflected in the biomarkers. And then you know you're rather close to the dementia stage of the disease. And now these models that have been, they are based on data, but cliff-jack made these curves to really visualize these types of changes, and it has helped us understand Alzheimer's disease quite well. And it also suggests that we have to, it also pinpoints what different stages of Alzheimer's disease one could start to intervene in depending on what types of drugs you are developing. And if you have a drug, for example, that is aimed at delaying the onset of the amyloidogenic cascade, then the cliff-jack curves show that you need to start when people are 40, 45, 50. It's very early. If you instead have a drug that is meant to detoxify or reverse the amyloid pathology in the brain, well, then you can start later. If this drug works before frank neurodegeneration has kicked in, then you will need to start when people are around 60, 65, and biomarkers could help to pinpoint what the target population of such a drug is. So I think these Jack curves, they help us understand the disease, they help us develop treatments, and they help us understand when the different treatments with a reasonable chance could have a beneficial effect on the patients. And of course, this is all based on biomarker data and to some extent genetics also, because the genetics come in here as well, because ApoE epsilon-4, the susceptibility gene for sporadic Alzheimer's disease, they make the amyloid curve switch approximately 10 years earlier per allele of epsilon-4. So that's also a very exciting, relatively new finding that one could use ApoE epsilon-4 together with biomarker evidence of amyloid pathology to determine how far a patient has come in the amyloidogenic cascade process. Jack curve, the first versions of the Jack curves did not have neurofilament light in them. Instead, the best neurofilament light then is a neurodegeneration marker. So NFL is a protein which is inside axons, much like tau, but it has a quite wonderful aspect as a biomarker. Whenever an axon is falling apart, then neurofilament light is released. So it's a general neurodegeneration marker. It is increased in people with neurodegenerative brain disease, irrespective of underlying cause. Total tau instead has an AD-specific pattern. So in Alzheimer's disease, total tau is increased, and it marks to some extent neurodegeneration of Alzheimer type, but it's not increased across the neurodegenerative dementias. And recent data show why. And the explanation is that amyloid directly induces tau phosphorylation and general tau secretion, which on the neuronal side. So both total tau and phospho-tau go up. But that is in response to amyloid. So to some extent, one could call total tau and phospho-tau as amyloid markers, but that might be to confuse the field. So instead, we often talk about them like amyloid-induced tau mismetabolism or tau dysfunction. This tau dysfunction will eventually lead to neurodegeneration. So one could also regard total tau and phospho-tau as predictive markers of Alzheimer type neurodegeneration and tangle formation, but not as direct markers of these two processes. Neurofilament light could then instead step in as a biofluid-based neurodegeneration marker. So I regard longitudinal MRI and longitudinal neurofilament light as rather similar markers, but then neurofilament light would be easily accessible through a biofluid. And now we also know that neurofilament light can be reliably measured in blood, and it has the same biomarker dynamics as in CSF. So we know that much of the CSF literature on neurofilament light can be translated into the blood studies that are now ongoing. And in the latest version of the Jack curves, Clifford Jack has included neurofilament light. So I think it definitely has a place in these models.